these advanced lesions. I give you Stephen Brown.
So my charge today is to develop with you conceptually why we might choose to use the laser as a single treatment without any other options. We all know that we have multiple options for doing these things. I didn't get a clicker here. We all know that we have many different options that we can use. What I would like to do is develop with you a concept for being able to overcome the etiology, to develop that etiology, and then be able to apply the laser as one of the things that will work. I'm humbled to be on this stage today. I've known Paul for a long time, and I've known Stu for a long time. They are the people who have written the book on peri-implantitis. So this is what we do in our office every day. We're using phase contrast microscopy, and we're using it to determine what the level is of infection. These three statements were the three statements that came out of the classification of periodontal and peri-implant conditions. It was the combined AAP and AAP and the European. I realize that the laser is a very controversial subject, and consequently, I think back to my former resident, Dr. Vico Cambra from Barcelona, Spain, who said, "A smooth sea never made a skillful sailor." We are in an age where we're looking for evidence-based treatments. We're in an age where we want answers ahead of time. But the reality is that we don't have those answers all the time, and it takes a while to get to them. It is said that in order to get something into the literature takes 2 years, and by the time it's in a textbook, it's 5 years. And after that, you'd have to think about somebody like Christian Barnard. If he had waited until it was published in a textbook, we probably would have never done the first heart transplant. So we're going to develop this concept from the beginning. Basically, does the literature support what the findings were, that the bacterial infection is the main cause of peri-implantitis? A recent study showed that 80% of the cause of peri-implantitis was pathogenic bacteria. All the others together represented approximately 20%. This was by Hector Sarmiento and Joe Fiorellini from the University of Pennsylvania and Michael Norton. Salvi and co-workers showed in 2017 that biofilm accumulation is what the biggest problem is. And it caused bleeding, and the tissue destruction on the implants was much faster and more extensive. It is postulated that this is because there are no supracrestal fibers, nor is there a periodontal ligament, so the breakdown from the bacteria is much quicker. Indeed, microbial plaque kills implants. So, now that we know what the primary cause is, which particular bacteria have been indicted in the causation of peri-implantitis? When Leonhardt and co-workers looked at it, they found out that 60% of the cases had periodontal pathogens. And the most significant one was Porphyromonas gingivalis, PG. In another paper, Botero and co-workers found P. gingivalis was detected in peri-implant lesions, but not in healthy implants. So when you see the problem, you're going to see P. gingivalis more often than any other. But it's bacterial in nature. Jan Linde ran a consensus report in 2008. What did they find? Bacterial causation, 80% of those people who have implants develop peri-implant mucositis, and over 50% have peri-implantitis. This is a staggering number, given the fact that we are thinking that implants, basically, we thought they lasted forever. They determined that you had to, in order to save these implants, institute anti-infective measures. And they also said that non-surgical methods were very unpredictable. The conclusions that they came to was that you had to open things up for debridement, you had to have something for decontamination, and they said that there was no evidence that purely regenerative procedures benefited treatment outcomes. DeWall and co-workers basically took samples of bacteria from patients with peri-implantitis, and again, their study showed PG was the overwhelming thing. The other three were also present. So, now that we know that bacterial infection is the cause of peri-implantitis, and we also know what the specific bacteria are that are the most prevalent and the most destructive, what's the evidence supporting the fact that lasers work to get rid of these bacteria? In 1992, Cobb and Macaulay and co-workers found when they used an ND-YAG laser in periodontitis, they found that the calculus, how do you go backwards? They found that the calculus deposits after the treatment were completely free of microbial plaque. And we know that it is the bacteria on top of calculus that causes the inflammatory response. And there was a substantial reduction of the three most notable pathogens. So if it's been done, though, with a laser, it's probably possible. What this shows, which is very important, is if you take the crown off, if you're going to treat this with just about any kind of technique, if you take the crown off, you're able to get better access. And in this case, to get the laser fiber parallel to the long axis of the tooth is going to work the best. So what were the papers that have shown us that this works? Gianelli and co-workers showed very clearly that ND-YAG laser irradiation was a promising method of treating peri-implantitis. They were able to blunt the lipopolysaccharide-induced inflammatory response, and in doing so, they were able to turn the situation around. And this is the kind of thing that we can see with the use of the laser. It's not that unusual to see results of this sort. Goncalves and co-workers showed when they used the laser for peri-implantitis, they got total decontamination of the implants that were irradiated. And most importantly, they did this without damaging any of the surfaces of the implants. This is another example of about 6 months to a year. Macaulay and Rams did a very interesting study. They took patients with severe periodontal pockets. They cultured those pockets. They then used the laser, and they found that 17 out of 20, 85% complete reduction of the bacteria. So I think you see where I'm going here. If we can reduce the bacteria, we can save the implant, or even in some respects, get some of the bone back, if not all of the bone. When they used ultrasonic root debridement alone, they only got 16.7%. So there was a major difference between the two. And this is one of Tom McCauley's cases, before and after. Grzelniak, Scully, and Gashperik, I can barely pronounce the names, did a study in which they used the erbium YAG laser and an ND YAG laser. They used them individually and they used them in combination. And what they found was that the ND YAG and erbium YAG used together had the highest bacterial reduction. They also found that the combination gave the greatest gain of clinical attachment. So they showed clearly that the laser could result in gain of clinical attachment on the implant. Another situation of about a year with the laser. So where does this leave us? Back when I was a resident, Dr. Walter Cohn used to say, that was the age that we were into resective periodontal surgery. It was hot. That was what we wanted to be doing. He was prescient enough to know that in the future, we would not be doing resective procedures solely, but we would be building back tissues. And we all know that today, everybody is in favor of minimally invasive procedures. Nobody wants to be cut. And the truth of the matter is we have arthroscopic surgery, we have microscopic back surgery. We're going towards the things that are least invasive. And when my patients come in, if they're given the choice between a surgical intervention and one that is not surgical in terms of cutting, oftentimes if we can get a similar result, they're going to choose the less one. We also know that we get great results with dental implants. But what we also know, after looking at them now for 10, 15 years, we're seeing a tremendous number of patients with peri-implantitis. So we're going to talk a little bit today about a technique that we use with the laser for treating peri-implantitis. This is a minimally invasive surgical technology. It uses an ND YAG laser with a 6.0 watt free running, free pulsed at a 1064 nanometer wavelength. What does that mean? You should know a little bit about laser light energy. First of all, it's monochromatic, collimated, and coherent. If you can put those three things together, you can alter tissues. We used a visible wavelength of about 1060 nanometers, and if you can get both of those things, then you're able to ablate the surface of an eye, and we're all familiar with LASIK surgery. So, what is the LAPIP protocol? It's the LANAP protocol used on implants with a lower dose level. It gives us several different things that help us in reversing the process. Indeed, it gives us all of the things that we want from traditional periodontal therapy. So let's go through the technique. Under anesthetic, we're going to probe. We're then going to do ablation of the pocket lining, and it's attractive because the pocket linings are pigmented. As I said before, we're going to run the laser fiber parallel to the long axis of the tooth, and in doing so, we're able to affect these changes. We haven't forgotten where we came from. We're using a high-powered piezo device to clean cement and calculus off the tooth. We haven't forgotten that we're periodontists. And by scratching the bone, there is a theory that says that we develop a RAP type of phenomenon, a regional acceleratory phenomenon, and we release growth factors. Then we literally poach the blood, the bleeding, with the laser set on a hemostasis setting, and it forms a gelatinous clot. And what that allows us to do is press the tissue against the implant without using any sutures. And where necessary, we do occlusal adjustment. So these procedures together alter the environment in favor of health, and oftentimes we can regenerate the lost attachment. So how does it work? The theory is that the laser light energy is attracted to pigments. It's attracted to colors. And the bacteria that cause peri-implantitis and periodontal disease are colored. It indeed is a heat-seeking missile. The other thing about the laser, it's pulsed so rapidly that there is no damage to the tissue. It's on 0.2% of the time and off 99.8% of the time. What's the importance of this? Well, it allows the tissues to recover. There's no burning, cutting, or destruction of the tissues. And following the treatment, the tissues look relatively normal, as opposed to major resective therapy. What happens is, sealing of the pocket, where we get the clot that I just showed you we can develop, it's like a membrane. This is all theory. It prevents the downgrowth of epithelium, which is going to cause the situation to get worse. And if we can promote healing from the bottom up rather than from the top down, we're going to be winning more often than not. You can deliver 2,000 watts right at the location of the bacteria without any collateral damage to adjacent tissue. We're doing this in millionths of a second, in microseconds. So it hits those bacteria, kills them on contact, no collateral damage to adjacent tissue. When we use the LAPIP protocol, we can get some really amazing results because of what it's able to do. And when you think about it, if you had a viable alternative to major intervention, to major surgical procedures, if that was your patient, or if you were the patient, what would you choose? So, what's the evidence for using the Nd:YAG laser and getting periodontal tissues healthy again? Well, we have to go to periodontium in order to see the benefits that we can get. And the paper done by Ray Yuckner, in which he took 6 block sections and was able to show complete regeneration of periodontal ligament, bone, and cementum. This is some of the histology from his case. What he showed very clearly was, this was a notch study. The bone level is above the notch. There's new cementum. There's new periodontal ligament and a short junctional epithelium, while in the other cases, he found that the bone levels were below the notch. There was a long junctional epithelium, very little new cementum, very little periodontal ligament. And Mark Nevins, who was here this morning, also did a study in which they showed very beautifully histologically, with using the laser exactly as we've talked about, where we had new bone, new cementum, new periodontal ligament. This is backscatter electron microscopy showing the bone. Now, I grant you that you may not be able to exactly apply that to an implant, but it seems like the same methodology should work similarly. That research still needs to be done. In 2016, the FDA approved this laser for true regeneration. And if we can get true regeneration, that's the goal, that's the objective, that's the gold standard. So this is one of my cases in which the patient came in. This is what they were showing on phase contrast microscopy. There was probably about a 9mm pocket with bone loss and about a 6mm pocket on this side of the implant. We took the crown off. As I said before, the reason for taking the crown off is so that we can get the laser fiber tip parallel to the long axis of the tooth. And you can see that in using this, you have very, very little bleeding, very little, there's no cutting, and you're looking down on it, there's hardly any disruption of the tissue. And over a period of time, you can see the changes in the tissue. Right here, it's quite discolored, there's deep pockets, it's hyperplastic, and then as time goes by, it gets better and better, the tissue color changes, and eventually we can actually see the top, the shoulder of the implant where the healing abutment meets the implant. And this is the course of 1 year. We've been able to take that defect and the one on the distal and literally completely eliminate them. This patient has got his implant, he's in function, he was not disrupted in any great way, he's a happy man. This was another case, and in fact, Dr. John Suzuki published this case, but this was my case that he published. This was a patient who I'd been seeing for about 6 years after the implants were placed. And she came in one day and there's suppuration, bleeding, deep 10mm pockets. And we said, you know, we've got to do something about this. And she didn't want to lose the implant and she didn't want to lose the crown. We removed the crown, put a healing abutment in, and within 24, 48 hours or within a couple of weeks, we saw that the tissue is still quite swollen, but looks a whole lot better than this. We did the LAPIP protocol on 12/13. In a month's time, you can see the change in the tissue just from that little intervention right there. The laser has taken care of the bacteria and the body has taken over and given us the healing. And within 16 months, this is what we had. So to show you this in time frame, this was when the implant was first seen by me. 15 months later, this is the way it had broken down to. It had broken down at this level. We did the LAPIP at this point. 4 months later, we're starting to see some regeneration of bone. A year later, we have significantly more regeneration of the bone. And 16 months later, we can put a new crown on there. I think that that's a tremendous service. I think that's an opportunity that we have to provide a service for our patients that is predictable, it is non-invasive, it takes care of the etiology, which would give us, under most circumstances, the best opportunity for us to regain the use of this implant and the crown that's on it. I love this quote because when we started talking about lasers, it was ridiculed. And second, it was violently opposed. And today it's accepted as self-evident. I think we're somewhere between violently opposed and self-evident. I never end a lecture without paying homage to the people who taught me. They were giants in the field. They were people who brought us up taught us all. Most of the people in this audience have been affected by them in one way or another. And I thank them every day for the opportunity to stand before a group and talk about the things that we're doing that are different than the ways that we did them before, that are more effective. Oftentimes, they are completely eliminate the need for some of those other procedures. And with that, I thank you very much for your attention.
That's yours, or? Yeah. So, unfortunately, our next presenter could not be here today. Dr. Frank Schwartz was called away due to a family emergency at the last minute, which meant that we were deficient